Thank you for joining our webinar, Obesity, Stigma, and Weight Bias, Understanding the Disease. We're so happy to be able to present this information and feature our speaker today, Dr. Valerie O'Hara, a pediatrician and childhood obesity expert.
Great. Thank you, Carrie, and thank you to everyone who's taking time out of their busy schedule today to join us. So weight bias, stigma, we're going to talk about this by understanding obesity as a disease. So what are weight stigma and weight bias? So by definition, it's an unfair and negative devaluation, prejudice, or discrimination about or against an individual or group based on their body weight or size. So weight stigma specifically is social devaluation of a person due to body size based on negative, unfair beliefs, mindsets, and attitudes. Weight bias is a distorted treatment and outcomes lacking objectivity in actions, policies, or decisions. And we know that unfortunately patients living with obesity experience many negative stereotypes. We see here they're oftentimes associated with terms like lazy, unmotivated, lacking self-discipline. This is really representing some prejudice that exists, that preconceived negative judgment about people based on their size, and ultimately some discrimination and unfair treatment due to body size. In terms of types of bias, we know there is explicit, which is intentional or conscious, and implicit, which is unintentional or unconscious. We know there's public. It also translates into our associations in terms of social units. And for our children, it's family, school, and work. But more importantly, we think about internalized bias, that which our patients feel towards themselves, and that negative impact on their interpersonal relationships. And children who experience bullying and teasing by their family were more likely to have significant internalized bias and carry that forward with them. We know that youth with obesity are more likely to be bullied than their thinner peers. Here's some statistics. Weight most frequently is the source of bullying for up to 40% of children. 95% of adolescents have observed teasing and bullying towards their peers. When I ask patients, maybe sometimes the easiest way to have that conversation at first is saying, have you ever witnessed bullying and teasing at school or home or otherwhere? And they'll say, yeah, I've seen it, or maybe I've experienced it. So it's a nice way to lead into that question. For youth who are engaged in obesity management, 90% shared experiences of teasing and bullying by their peers. The most common reasons for bullying, we can see here, this was looking at 4 different countries across different reasons for bullying. And we could see on the left here that being overweight far exceeds the reason for bullying compared to sexual orientation, ethnicity, religion, family income, physical disabilities, and others. So how does weight stigma impact health? And we know stress has a lot of negative impacts on our eating and physical activity behaviors, as well as our physiological reactivity. From a healthcare quality, patients who are living with obesity experience poorer treatment adherence, less trust of their healthcare providers, avoidance of follow-up care, and delay in prevention of healthcare screenings ultimately. And if we take this collectively, we know this can worsen obesity. We know that it worsens psychological distress. It can create or worsen existing anxiety and depression. And from a physiological health perspective, we know patients with obesity experience lower overall health-related quality of life. And we see this even in our adolescents. So how do we acknowledge the complex etiology of obesity? We can understand there's physiology here. Then we can move past this first square where this is all about individual choices and behaviors. That increases stereotyping and stigma for people with higher body weights or with obesity. So if we change that narrative and we start with the premise that there's genetic and biological underpinnings along with the environmental, societal, psychological, and behavioral factors together, we can hopefully reduce weight stigma because we're improving the understanding of the complex etiology. So we know our body has many, many homeostasis mechanisms set in place to control our body functions, whether it's our blood pressure, our electrolyte balance. This is happening at the subconscious level. And the same is true that the body seeks a stable fat mass, just as other regulated tissues do. With that, we also know that obesity is a highly heritable chronic disease. And we know that heredity plays a 40 to 70% dominant role in the risk of obesity. So I think this triangle in this perspective is a little bit different than that prior narrative where we were looking at this as personal choices or all about just about the environment. We know that there's this biology, genetic risk with the environment and personal choices on top of that. So I often start And I share this visual with my patients and families. The energy regulatory system physiology oftentimes drives the behavior rather than behavior driving the physiology. And I say there's three parts of our brain that we're thinking about when we talk about the energy regulatory system. We have our cognitive thinking brain, where we're learning about healthy foods and portions and my plate. Then we have our metabolic brain, where it's getting nutrient sensing hormones that are coming up to the hypothalamus and from the periphery that are informing the brain about what are our energy stores. And on top of all of that, we have the hedonic or reward center of the brain that is looking at the salience of food. It smells good, tastes good, I want that. And all of this is all talking, cross-talking to help inform us about our energy storage and whether or not we need to take in energy or feel full. So we have that physiology here introducing into this our obesogenic environment. Treatment of obesity requires our attempts to best focus on those pathways and re-regulate that physiology or that fat mass set point. So if we use our old adage, just eat less and move more, and when we overly restrict calorie intake and increase physical activity alone without addressing that physiology that is dysregulated, we may lose weight, but then our body is sensing that change. And what do we see? We see the satiety hormones go down, hunger hormones go up, our metabolism slows, and weight regain occurs. We also know that there are critical periods of development where obesity may occur. What's causing that dysregulation is different across the lifespan and for different patients. And particularly for pediatrics, we know there's times of risk. Maybe it's prenatal and infancy, early childhood. And again, during adolescence, the impact of puberty, we know, can be a time of that dysregulation. And when that occurs, it's high risk to persist into adulthood without intervention. And we know obesity impacts all the body systems. In the adult literature, up to over 200 complications may be obesity related. With worsening obesity prevalence, we have seen these occur even in our youngest of children. So I want to switch gears a little bit as we think about bias and stigma, the words that we're using, the words that our patients are using. So one of my former patients shared an early letter, and these are his words. Obesity has been a problem that has plagued my life for many years. Before, I had tried several different methods of weight loss. While these diets and programs provided temporary success, they ultimately ended in a return to my old eating and exercise habits. Since I started the program, however, this has drastically changed. I also discovered that I have sleep apnea. I was able to get a CPAP machine to treat this affliction. They look at every possible factor that could be contributing to a patient's weight. There are many other children and families with the same or similar weight problems that I have. If they had access, their lives would be changed for the greater. And this patient's mother also shared her perspective. He has struggled with being overweight most of his life. His self-esteem related to his weight was at an all-time low. He would often joke that he would be lucky to live to be 30. I knew he was afraid of what the future held for him. Not only was he afraid of the future, he was struggling with the present. As his mother, I was feeling shame, grief, and worry. I felt like I had failed him. From the very first meeting, the staff made us feel at home. It has also given us strategies, knowledge, options, and ideas. As his mother, I no longer worry if he will lose weight. I know that he will. He will be a highly productive citizen and will make the world a better place. Powerful words to think about. The American Academy of Pediatrics provided this clinical practice guideline addressing the key takeaways that obesity is a complex chronic disease, and the comprehensive whole child evaluations are vitally important. We need to be treating obesity along with those comorbidities, and children with overweight or obesity should be offered treatment upon diagnosis. No more watchful waiting. Because we know what happens when we do not treat childhood obesity, and we now have significant data in the adolescent and childhood population. All of this comes to a head when we think about quality of life, those social issues that lead to lower quality of life for our children. So the major challenges to effective obesity care, really, we need to look at perceptions that obesity is not a disease. When we think about obesity-related prejudice and stigma, there's discouragement for patients seeking care. There's stigma against providers, limited availability and reimbursement, and barriers to the development of new novel therapies as well. In spite of all of those things, this is still an exciting time. We're improving the number of effective tools and combinations, and we're learning so much. So our key messages for patients and family is obesity is not your fault. Obesity is a heterogeneous disease. We need to treat obesity like any other chronic disease, connecting to a patient, offering treatments that can make a difference. And when a treatment doesn't improve the disease, the treatment failed, not the patient.